Yes, sir. Can we start, sir, with
Yes, please.
introduction? Yes, thank you. So, good evening, everyone. And on behalf of Venki's Nutrition, I'm Prasanna. Pleased to welcome all the participants to this exclusive webinar on standardization of blenderized feeds, IAPN India recommendations. I thank to IAPN India Association for this organizing this important session and giving us the best opportunity to be part of it. As you know that the purpose of today's webinar is to bring clarity and uniformity to the way blenderized feeds are planned and used in clinical practice. I hope this session will help all of us to understand recommendation in detail. I appreciate the presence of every participant who joined us today. With this, I will not take much time and it's my privilege to introduce Dr. Shushankar, President of IAPN India. As all of you know that Dr. Shushankar has been a strong force behind many initiatives that promote best practice in nutrition across the country. So now I hand over this session to Dr. Shushankar, who will take forward and moderate the discussion. So please, sir.
Thank you, Prasanna, for all those good words. And thank you for providing all the logistics to
Yeah,
organize this event. And we look forward getting your support in the near future as well. Thank
sure,
you
sir.
once again.
Yeah,
Welcome to
thank
all for this evening where we are experimenting kind of a thing where um, lot of blenderized feeds, whether they are able to adequately provide the nutrients, whether they are easy to plan, prepare, and administer, and how fast it can be to plan as well. So there are many things when it comes to the blenderized feeds. We all are used to using the commercials as well. Nothing wrong in doing that. But at certain places or where affordability is a question and where manpower is available, and if someone is preferring homemade feeds, so IPL India thought about creating a task force to come out with a template kind of a thing for various clinical conditions where blenderized feeds can be planned easily, seasonally available, regionally available food items can be included, and the plan can be replicated in various regions of India as well. So this is the reason why we came out with this task force and the recommendations. Before we begin with the first presentation, few things I would like to make it very clear over here. The content provided in the book should not be copy paste kind of a thing. This is a template which has been provided to you all practitioners. You have to use this template and rework out on the adequacy requirement of the concerned patient, considering the height, weight, symptoms, and the clinical conditions. You need to modify. So please note that directly you should not be just copy pasting the things what has been shown in the book, but it is a reference for you all to adjust to your regional preferences and locally available food items, and then you can plan for that one. We have given various options also in the plans if you are not able to get a particular kind of a food ingredient, food item. So what is the alternative which is available to you all? So you can look out for the available other alternatives and then accordingly you can plan. When you are going to use the book, please read the disclaimer as well. Please read the instructions also. Why? Probably during when you go through the content of the book, you may come out with some few questions which you may feel ki why this is being done like this or why it is not being done in a different way. Why they have used 48.3 grams, why they have not used 50 grams. So certain questions which might have come to you, but you need to understand that all these figures and all these, as I did mention about, it's kind of a template. It's a reference to you. So you have to use this reference and modify as per your requirement. For calculation basis, at certain places, we have used the decimals just to keep as far as the best accuracy we can and to move forward to get the right kind of a composition for the patient who is in a need of it. The book will be available from this Monday, from the 23rd November 2025. You all can use the link which is in circulation in many of the uh, social medias. However, we are going to put it across to this presentation also in the text messages where you can book the uh, you can pre-book the this edition. So, not wasting much time, I would like to invite our first presenter, Shefali Mehra. Shefali Mehra is the chief dietitian at NGM Hospital, Navi Mumbai, and she is going to present her presentation on the enteral feed on the subject what she is going to discuss about it. Over to you, Shefali.
Thank you so much. A very big thank you to Shiva, Shilpa Thakur, and the entire team who made this initiative possible. As Shiva rightly said, basically, this is for people who show, when we have to show empathy to some patients who are on RT feed and they're, yearning for kitchen feeds. There is a lot of hard work, lot of mindfulness, and lot of teamwork gone into these special feeds. And as he said about the disclaimer, we have to see and use it as and when our patients need it in the right way. So for me, my today's topic is high calorie, high protein enteral feeds. So what are high calorie, high protein enteral feeds? Specialized formulation to min screen share. नहीं हुआ? You all can see my screen?
No, ma'am, it is not
No,
visible.
Okay, I'll just a minute. Hmm. Yeah. Can you see it now?
Yes, ma'am, yes.
Yeah.
put it on the
Okay.
slideshow, Shefali.
Yeah. So, what are high calorie, high protein enteral feeds? Yeah. They are the specialized formulas which meet increased metabolic demands, and they are you can give them in catabolic stress, malnutrition, or conditions with elevated nutrient demands, oncology, critical illness, trauma, burns, sepsis, post-surgical recovery, chronic wasting disease. So these are the cases where we actually look at very high protein and high calorie feeds. And what are the significance of these kind of feeds? They are to maintain your lean body mass, to support wound healing, and to prevent negative nitrogen balance. And what are the principal formulas for these? Energy density. So now when you're looking at an energy of 1.5 to 2 kilocalorie per ml, these are the high calorie and high protein feeds which you can give it to your patients. They allow the calorie delivery in small volumes. They are very beneficial in patients with fluid restriction or poor volume tolerance. You also know about protein enrichment. When you have to contribute 20 to 25% of your planning to your protein requirement in a plan, and the protein to be given to your patient is 1.2 to 2 gram per kg per day, then these plans are going to be very, very beneficial. What is the macronutrient composition of these plants? Fat up to 50% of calories, which improves palatability and are energy dense. Carbohydrates, moderate to reduce hyperglycemia risk. Fiber, soluble or mixed fiber, aid bowel regularity and gut microbiome support. Micronutrient density, which basically goes, uncalculated many times. It enhances the levels of zinc, selenium, vitamin A, C, E, and B complex, supports wound healing and immunity. It also improves your osmolality and digestibility and optimizes fat blends, that is like your MCTs, for easier digestion. Now, when you are making these plans, What are the clinical indications for which you require higher? This is very, very important for you to have these kind of tables in your department. Hypercatabolic conditions, where you see your patient who are having severe trauma, burns, sepsis, major surgeries, critical illness, or treatment which has severe malnutrition. How does your high protein requirements come up? Where there are pressure ulcers, post-operative wound healing, chronic infections with high protein requirements. Elevated calorie requirements, your COPD patients, cystic fibrosis, chronic inflammatory states, hypermetabolic conditions with increased resting energy expenditure, or fluid restriction. As we all know, if there is a heart failure or a congestive heart failure, a renal failure or pre-dialysis, there your fluid has to be restricted. So your these plans would work. And in certain cases where you have very poor oral intake, like dysphagia, neurological impairment, anorexia, or a very long, prolonged hospitalization. Now you have to be very careful when you are planning all these for your patients, because there are contraindications. What are your absolute contraindications for high protein, high calorie plans? Complete bowel obstruction, severe paralytic ileus, intestinal ischemia or uncontrolled shock, high output fistulas, not bypassable distal to fistula. And what are the relative contraindications? Severe malabsorption, unless formula adopted, uncontrolled refeeding risk states, severe hyperglycemia, persistent severe diarrhea, or intolerance to high density formulas. And what are the precautions that you will take when you are giving these feeds to your patients? Gradual initiation. So you never give a full feed on the first day. You start with a 25 to 30% of target rate and gradually increases. You have to manage the glycemic index of your patient if he's a diabetic. You have to see the GI tolerance, assess discomfort, residual vomiting if the patient has vomiting or diarrhea. You have to check the fluid and electrolyte balance. High concentrated feeds alter hydration. So you please monitor the sodium, the bun fluid input and output. Risk of refeeding. So you have to make sure there is a correction of phosphorus, potassium, magnesium, and thiamine is also supplemented to your patients. So this slide basically shows you what are the contraindications when you are not going to use these kind of feeds, and the precautions that you need to take. So these feeds will not be there for everybody. We have to be very, very careful when we plan them. Now, what are the troubleshooting points? Diarrhea. Suppose your patient has diarrhea, slow rate of advancement, switch to fiber enriched or semi-elemental formulas. If the patient has constipation, increase water flushes. Consider fiber containing formulas. Add stool softeners if it is required. High gastric residual volume. Re-evaluate positioning, keeping head elevated 30 to 45 degree. Consider prokinetics, jejunal feeding for persistent intolerance. And if your patient is going through hyperglycemia, adjust carbohydrate, optimize insulin, considers diabetes specific. So the ingredients which are there in our plans, what you can do is you can, as Shiva mentioned, you have to see who is your candidate, who is your patient, and you have to follow these plans as a reference and not do copy paste. Dehydration, hypernatremia, provide additional free water, monitor serum sodium very closely. If it is intolerance, then advance to other concentrations. These are the references from where we have worked on the plans that we have put in the booklet. So according to that, you can go through the plans once the book is available. Thank you so much. I hope this was informative.
Thank you, Shifali. Yeah, there's one question for you in the chat box. How you can ensure the micronutrient density when you're planning, when you're going to plan a blenderized feed through the kitchen? So,
Once you have the ingredients and you have the list to the contents, you can make sure that those are micronutrient are calculated. Suppose sometimes it is not reaching to the optimum, then you can add a supplement to these feeds. But the absorption is always good when it is in water. So you have to make sure that your calculations you calculate the micronutrient. We have done that in the plans.
You can refer the planning in the book where the micronutrients are also being calculated, and the Excel list is also being provided for each of the presentations. So if you're looking out for a particular kind of a micronutrient or in general all the micronutrient, everything has been taken care in that.
Yeah, in the plans all
And
are there. I have not put the table
now
here actually.
yeah, yeah, go ahead, go ahead.
Yeah, it's there in the plans, but we have not put the tables here on the PPTs.
Yeah. So what kind of characteristics make a formula high calorie, high protein? How you define that this is the high calorie, high protein?
So high calorie, high protein means we will be selected those kind of foods which actually when combined give you that much amount of calorie and proteins. So there are some
Nutrient dense.
examples. Yeah,
Hmm.
nutrient dense they are. So probably when you are wanting to look at a 2000 kilocalorie plan, or you're looking at 1.2 to 2 gram per kg body weight of protein, we have selected those nutrients, and it is selected from different areas of India. It is multi state. We have selected the cereals, pulses, and some of the other ingredients which we have combined to make these plans.
I think that plan is of more than 2,400 calories and more than 80
Yeah,
grams of protein,
yeah,
what
yeah,
you
yeah,
have planned out.
yeah, yeah.
That gives a really kind of a buffer to alter the kind of requirements one would need about. Even if
Yeah,
you would like to increase 200 calories and 10 grams of protein, that also can be done. For vice versa, if you would like to
we
reduce
can.
also,
Yes, we
so that
can.
template can be altered. So in that
Yes.
way.
Yeah.
Thank you, Shifali, for that wonderful presentations.
Thank you so
So
much.
may we move to the next one. So our next presenter is Snani Surendran.
Yes, sir. I am here.
Snani, you are there, okay. Snani,
Yes,
she is the chief dietitian. Can you just
yes, sir.
introduce
I will
Snani,
share.
which institute you come from, and please begin your start your
Yes,
presentation
sir.
as well, along with that.
Myself, Dr. Sinani. I am working in MBR Cancer Center. It's a cancer center residing in Kerala. Kozhikode is a city. And I am practicing here past 8 years as an onco nutritionist. Now I am going to describe you the diabetic enterophid possibility we can give to rise to patients. Good evening, everyone. I'm going to describe the diabetic enterophils possibility. As everyone know, and it's critical for all the multi-specialty that we have to feed diabetic patients to rise to. And people with diabetes find what to eat as the most challenging part of the treatment plan. And American Diabetic Association recognizes the integral role of nutrition therapy in overall diabetes management. Every person with a diabetes should be actively engaged in self-management, education, and treatment planning, and customized and individualized eating plan is essential for the same. We can't have a one-size-fit-all approach while making a diet plan for people with diabetes. Hence, the diabetic patients receiving two feeds need careful carbohydrate management too. And the indication is the patient with confirmed diabetes and unstable blood sugar due to metabolic insufficiency or treatment toxicity. And the blood values fasting blood sugar greater than 126, 2 hours plasma glucose, oral glucose tolerance is greater than 200, HbA1c greater than 6.5, and the random blood glucose level more than 200. So we have to focus on diabetic enterophid formula. Classic symptoms of hyperglycemia, hyperglycemic crisis. If the patient have the same, we will go with this diabetic enterophid formulas. And the dietary recommendation is macronutrient composition almost carbohydrate 50 to 60%, fat 20 to 35, protein 10 to 20, 0.8 gram per kg per day. And dietary fibers is more concentrated in diabetic formulas, 20 gram per 1000 kilocalories. And along with that, we have the micronutrients, vitamins and minerals in them. And do's and don'ts, Use low glycemic index ingredients, mainly oats, legumes, vegetables, include lean proteins, egg, curd, paneer, tofu, dal, include healthy fats, olive nuts and seeds, finely blended. Measure carbohydrate carefully, dilute feeds to correct viscosity, maintain strict hygiene and food safety rules. Use a fine strainer before administrating the feeds. And what to be don'ts? It's avoid sugar, jaggery, honey, glucose water. No high GI fruit should be added in the feeds. Do not use unstrained lumpy mixtures. Can chances of tube blockage. Avoid feeding about 2 hours after preparing. It's not refrigerated. It's a part of food hygiene also. Don't rely on guesswork for portion sizes. Don't give raw leafy vegetables. It's hard to blend and smooth. Go through the feeds. And this is an essentialist, but you just have, we are focusing on the cereals, rice flakes, brown rice. The cereals are mainly lower glycemic response and have a slow release carbohydrate, prevent the blood glucose spikes. The cereals are the source of high fibers also. It have soluble as well as insoluble fibers and supports gut microflora. These fibers ferment into beneficial short chain fatty acids, improving the metabolism. The cereals also help to improve the stool consistency, provide essential nutrients. And what how the cereals should be main absorbable, which reduce the nutrient loss. The cook with the least amount of water to avoid vitamin losing. Use cooking liquids in the blend contain minerals and B vitamins. Avoid high heating after blending. This all will destroy the vitamins. So cereals, along with the cereals, different types of pulses also uses for having preparing this enteral formulas. By adding the protein also, we can reduce the glycemic balance. We can maintain the glycemic balance and good glycemic response, as well as the nutrient density can be preserved. And coming to the vegetables as well as the fruits, we are added to the same, and this all will help us to increase the fiber content of the enteral feeds. Nuts is a main source of healthy fats, and it slow the glucose release and improve the calorie density. And we are using milk as well as good oil contents, easily absorbable, and salt, lime, turmeric. This essential contents will be it's not for taste. We know the micronutrients is there in the spices. They are medicines too. Then for having this, we just have a take home message that food safety is most important in the part of blenderized feeding. Diabetic to feed must ensure controlled carb plus high fibers. Carbohydrate control is a key role in blood sugar stability. Homemade feeds must be carefully blended, strained, and safely handled. Monitor glucose regularly and adjust ingredients as needed. And as a conclusion of this diabetic enteral feeds, blend-rice feeds are feasible, nutritious, and economical if done hygienically. Thank you.
Thank you, Snani. That was really a wonderful and very clear but kind of a message you have given how to plan the diabetic enteral feeds. There is a question I would answer for that one. Are these feeds tested for osmolarity? No, the feeds have not been tested. As I did mention about, it's just a template and it's not a kind of a formula what we are recommending. And the osmolarity will marginally will be differing as per the choice of the food items what we include from
Yes,
the
sir.
choices given in the book. So rest assured that the osmolarity will be still acceptable unless until the patient themselves, the individual patient is intolerant to certain kind of an element. So it's not regarding the osmolarity, it will be regarding the intolerance. And if you all will see that
Yes, yes.
all 100% of the feeds are simple sugar free, so the osmolarity will be more or less will be taken care of, and even adequate number of amount of fiber are also being included. So that gives a little kind of a
Yes.
leverage to say that yeah, the feeds can be safer. However, having said that one, you when you are going to use that template and when you're going to plan, you can have your own calculations done for the osmolarity. Snelly, one question for you, like which ingredients and methods help to improve fiber level in blenderized food? That's the toughest part, no, including the fibers. And as you did mention about 20 grams per
Yes.
1,000 calories, it's very nice to really speak about, and but when it comes to the practicality, we have challenges. Can you just throw some
Yes.
light on that?
Yes. The main source of fibers we know it is from fruits and vegetables. So for that we have two types of fibers, insoluble and soluble fibers. Insoluble fibers we know it is present in skin, peels and seeds, cell walls, etc. In the soluble fibers in pectin, gum and mucilage. For the insoluble fiber, cook with the skin, then blend very smoothly. Then avoid juicing. You just have to blend the entire vegetables and with minimal water, so we can use. Then lightly steam or short pressure cook preserve the soluble fibers also. And one thing we have to make sure in a medical condition, if we have to remove, for especially in neutropenic diets, we have to remove the skin and peel. We just focus on the soluble fibers in the case of fruits and vegetables. And the second, we can also legumes and pulses also can be preserved. The fibers can be used for soak for whole pulses for overnight 8 hours, and pressure cook with minimum water 10 to 15 minutes. Use that water also for cooking purpose. So in the same way we can preserve the fibers also. So it is all depending on the
So,
medical condition. Soluble fibers can be given to any condition, but in case of neutropenic, neutropenic diets, we have to remove the skins, and insoluble fiber will be compromised.
no, if it is boiled, you don't have to again throw that out. The skin can still be used if it is been cooked and hygienically being
Yes.
utilized.
When
There is one more question put up, Snani. Can fiber supplement be given through the blenderize? Would you like to answer that? The fiber
Yes,
supplements.
the fiber supplements.
You
Most
can.
of the fiber supplements, like isogold, can be added to. The supplement can be of different types depending about the solubility. We can add to the different types of kitchen feeds. But the total calculation and the mode of absorption should be in our risk. We have to just go through it. And second thing, when we adding the soluble fibers, you just see whether the stool consistency also. It is the motility and how the patient, the many of the patient, the YouTube feeds have the chance of constipation as well as the diarrheal episode. So when we add as extra the fiber requirement as supplements level, also we just focus on the patient's their general daily conditions.
I would just elaborate for a following question over there in the chat box. So yeah, fiber supplements when you are choosing, choose the resistant fibers so that they don't block the tubes when it is being fed. Uh, there
Yes,
are
yes.
there were few suggestions like can we blenderize the isabgol and can it be given? It's quite
Yes,
difficult, and if the temperature is also slightly cool in the room temperature for you, it's a air conditioned room and probably the regional temperature is also quite cold. So the solidification, the viscosity immediately increases. So resist from using certain kind of fibers. But if it's a resistant fiber which are easily available nowadays in the market, so that can be added to your feeds. So you can use that one. We are coming to the jejunal feeds as well, the question which propped up. So we are going to discuss even that. So thank you, Snani, for that wonderful presentation and good interaction as well.
Thank you, sir. Thank you very much.
Yes. So we have Shruti Bharadwaj from Ahmedabad, and she is the Chief Clinical Nutritionist at Zydus Hospital, Ahmedabad. Welcome, Shruti, and
Yeah, thank you,
uh,
sir.
yeah, please go ahead and present your plan.
Yes. So thank you, sir. So when like my I will speak on enteral nutrition in dialysis patients. So we all know when it comes whether the patient is on hemodialysis or peritoneal dialysis, definitely the patient nutritional requirement becomes high, whether meeting the calorie or protein requirement. So there are certain indications that when we can start enteral nutrition if a patient is malnourished, inadequate oral intake, maybe more than 7 days, and the patient is not well eating, so we can start enteral EN also. There are certain associated acute illness also here. Then, and the last is pre-transplant support, because all of these patients, these are the indication we can start enteral nutrition for patients who are on dialysis. Now, when we are planning any enteral prescription for dialysis patient, there are certain key consideration we need to take care, like meeting take care of the phosphorus monitoring. It is very important. The protein intake, how much we are able to meet, the quality of protein here, all these things matters a lot. And the feeding modality also. In feeding modality, all things like because all these patients are on fluid restriction also, so definitely we we can't give so much of feed volume. So we need to take care that which feeding mode we are giving, whether continue feeding, whether bolus, whether intermittent, and also along with that the total feed volume that we are giving along with the total liquids, because in all these patients we need to take care about the flushing water that they are using. So all these things will come under feeding modality. Now, when it comes to nutritional target, we all know that among the patients who are on dialysis, the calorie requirement we need to meet up somewhere 25 to 30 cal, the protein 1.2 to 1.5. But as all practicing dietitian will agree with me that it meeting this much of calorie and protein, and for patients who are on dialysis, sometimes it is very difficult also. And many a times we always focus on meeting protein, but also we forgot about non-protein calorie that also matters a lot. So in all these patients, those who are in catabolic state are malnourished, so we need to, along with protein and total calorie, we need to focus on non-protein calorie along with electrolyte, mineral, definitely phosphorus, potassium. All these plays an important role. And at last is feed volume, as we had discussed that all these patients may have fluid restriction, so we need to focus more on the concentrated feeds. Now coming, as you will review very soon, the book is available. So what we did, like there are we made the feeding chart as per the food exchanges, like how if we have to meet 2000 kilocalorie as or 70 grams of protein. So these much of exchanges we need to consider, like cereal 8 exchanges, pulses 4 exchanges, vegetables, fruits maybe 100 grams, 80 to 100 grams, and seeds of 10 gram, nuts also 15 grams. So these are the 10, exchanges that I am highlighting here. So
Shruti,
yes, sir.
sorry to stop you. We can't see your slide.
Sir, it is visible. Can I stop share and again redo the screen sharing? Please confirm.
Yes. Nancy,
Okay,
please stop sharing your screen.
I'll do again.
Yeah.
I think someone is doing the screen
Nancy,
sharing.
please stop sharing. Nancy is doing it. I mean, like,
I'll wait for a second, ma'am. No problem.
yeah, I think you have to reshare the slides.
Okay. Yes, but because it is still showing the
Mm-hmm.
other, no problem.
Meanwhile, I would answer the few questions which was left out in the previous presentation. The resistance fibers, you can look out for what is available near to you. But to name some, I can say any hydrolyzed fiber as of now which is available. The source can be a guar gum or it can be inulin or even soy polysaccharides are also available. Cellulose is available, but the hydrolyzed gorgum is most easily available to you all. So look out for that hydrolyzed gorgum for resistance fiber if you would like to include in your feeding. Yeah, over to you, Shruti.
Yes, sir. I hope it is visible now.
Yes, yes.
Yes. So I was at the exchanges that if we, this is a prescription, if we want to plan 2000 kilocalorie and 70 grams of protein, along with taking care of phosphorus, potassium, all these are important for dialysis patient. So here are the amount per exchange we need to take care, like cereal 8 exchanges, pulses 4 exchanges. How we can break when it comes to feeding patients, so that we mentioned in the book the the feeding composition and all. So these are the exchanges I am only highlighting here that we can consider. And definitely there are certain precautions we need to take care while planning a enteral nutrition for dialysis patient, that electrolyte dearrangement, volume overloaded, because many a times we know that we have to plan 1 liter of feed, but along with 1 liter there are certain staff is also using flushing water, staff is also using free water for medications and all. So probably we need to, as a teamwork, we need to take care that how much is a patient is not, patient should not overloaded with volume, and the GI contraindication. And definitely the last is hypotensive episodes during dialysis, which is very common during dialysis, that patient may develop hypoglycemia and hypotension. So we need to avoid feeding at in this condition. Yeah, thank you so much.
Thank you, Shruti, for that wonderful presentation. I think renal is one of the most difficult part to plan.
Yes,
Tell me,
definitely.
what difficulty, in practical reality, what difficulties you found while planning? So that let the audience also get, when you would like to plan for a dinner diet, and how you overcame those difficulties.
So the major challenge is like meeting protein requirement first, right? Because we have to, if your patient is on peritoneal dialysis, we have to give more protein to all to patients who are on peritoneal, and meeting, sometimes meeting 1.2 also it becomes very challenging. And when it, definitely here is a need to add of ONS also. But when it comes to meeting ONS, we need to take care, we need to check so many things. The supplement should be calorie dense, and we can meet up major calorie. And now apart from protein, we the managing electrolytes also, it is very important, because the patient who are on dialysis, maybe in on a monthly basis or once in 15 days, they have to check their electrolytes, potassium, sodium, right? And every time they will not come to us for the follow up. Suppose if I'm look, yes. So
Just tell me, suppose if I have seen, but just for the audience, now seeing that template, you have considered all the electrolytes are being in check, like low electrolytes and adequate amount of other nutrients.
yes, yes,
So it
sir.
is being taken into consideration. So
Yes,
if
it
some,
is
now
being taken into consideration.
yeah,
Yes.
if you would like to advise someone, okay, how easy it will be looking at the template and to plan a renal diet now. How much
Sorry.
time they would take? How easy and how much time anyone would take to plan a renal diet now after
Sir,
looking at the template?
it is very difficult to plan a renal diet. Sometimes it takes 40
No,
minutes.
now you are no. After seeing your template, what you have made the template in the book. Now, if someone would refer to that one and plan a renal diet now. So
Yes.
how easy and how fast it will be?
Definitely, sir. We now our exchanges we had mentioned, like if we want to meet 2000 kilocalorie and this much of protein, so we had given an example in the book that these much exchanges. So it is very easy. Like now, if
Yeah,
I want to meet 2300, so for me it is easy to increase a few exchanges in the food item, but it is like it will take hardly 10 minutes or maybe less than 10 minutes.
right, right.
Yes.
So that's really so wonderful.
Yeah.
People, as we grow up on, we lose our basics, and
Yes.
very rarely if we are going to see renal cases. So this becomes so handy. Immediately, you just refer to that book. Would you say that it will be more faster than the AI?
Definitely, yes, sir.
पुलिस में ट्राई
So
नहीं
nice
मारे
of
क्या
you
There
to
is
say
no
that.
doubt.
हम्म?
Yes.
So
यहाँ
nice. Yeah,
पुलिस
and
में
it
ट्राई
is,
नहीं मारे
पुलिस में
पुलिस में चाहे आर्मी में
and
नहीं
it,
नहीं
uh, please mute yourself. Yeah. Trust me, it will be really, really very easy and really more faster than AI. Why is it so? AI will give you so many options. You'll get confused and
Yes.
exactly how much of what ingredient of which country it has used and what are the calorific values in those countries of the same ingredient. You would agree that certain ingredients, say for example, almond or maybe a walnut, what nutritional density it has in India, it may differ around 10 to 20% somewhere else as well. And when it comes to the renal diet kind of a thing, even a little bit of deviation does matter a lot when it comes to a routine kind of recommendation where enteral feed will not be for a short term, probably it may be for a longer period of time. So that gives you really a very handy kind of a thing. Thank you, Shruti.
Thank
And
you, sir. Thank you.
yeah. Uh, we have now Dr. Nancy Sani, and she is from PGIMR Chandigarh. Nancy, are you there? Is Nancy there for our presentation, or should we go to the next one?
She's there, but there is some delay.
Okay, we can go with the Koel till then. Koel, are you there? Koel?
Yes, sir. Yes, sir.
Yeah.
Good evening.
We have Koel Pal Chaudhary from Kolkata, and she will be presenting her entrance feed. Can you please introduce yourself much better than what I've done, and please go ahead with your presentation.
Thank you, sir. And I am Dr. Koelpal Chaudhary. I'm a research dietitian of IPGM and SSKM Hospital, Kolkata, as well as I'm the early career faculty in ESPN now. So thank you all my co-authors and Shiva sir for giving me this opportunity. Just give me a moment. I'm sharing my screen.
It is visible.
Yeah, thank you, sir. So I am going to highlight very baseline thing: when, how, and what kind of feed, what kind of enteral feed should we administer as soon as possible. So just a moment. Yes. So for immediate basis, the most recommended one is NG tube, means nasogastric tube. This one, the most common thing, the short-term tube, and the placement could be occurred in bedside. Suppose the patient is anorexic or having very dysphagia or kind of complication, patient is admitted in ICU. In this case, the safe side is we should go for NG tube. But here is some complication. There may be nosocomial infection. There could be aspiration, displacement of tube. This could be the complication. But wherever suppose the patient is suffering from neurological disease, head and neck cancers, some post-operative complication, then we should go for PEG tube. That means percutaneous endoscopic gastrectomy tube, this one. So this is called the long-term tube. And here again the problem is, yeah, there could be infection, there could be intestinal wall disruption. It is called buried bumper. So this could be a problem over there. And in some specific cases, we should go for jejunostomy. Dipti ma'am will be highlighting more on that. But in some cases, the surgical insertion of tube directly into jejunum is there. But again, there is some tube blockage, there is some diarrheal condition, and in a nutshell, in 3 of the cases, the infection, displacement of tubes are very common. Now, basically, as per international guidelines, definitely we should shift the patient from enteral to oral as soon as possible. So the tentative duration of those tube is 4 to 6 weeks. But if the aspiration risk is very higher, we should go for jejunostomy feed directly. Now coming to the point, what kind of foods to be allowed, what kind of foods should we avoid? It's again a very baseline agenda. Yes, definitely we should incorporate the locally available cereals, millets, different kind of vegetables. Yes, different mixture of nuts and seeds, dals, pulses, and definitely the milk, soy products we can choose. But what foods not to be allowed? Suppose some starchy foods like potato, like corn, some viscous foods like ragi, lettuce finger, oats, and some fibrous fruits like pomegranate, mangoes, bananas. It may hamper the consistency of the foods and it may hinder the dilution rate as well. So in a general way, we can avoid this kind of foods. Now I'm coming to the checklist part. Yes, definitely before having the riles to feed, we need to calculate the patient's actual requirement, and then we need to cross check how much the patient is consuming. So the requirement versus consumption or intake ratio should be on check, because we should ensure the nutritional adequacy first. And secondly, Weekly, the anthropometric measurements like height, weight, MUSE should be done. It is another considering point. And apart from that, we should go for the fluid balance chart. Means input-output chart is again very important because the patient should be hydrated all the time. We need to check the intake fluid as well as the urine output. Now, if I'm coming to the laboratory reports, yes, electrolyte balance should be there. So sodium, potassium, magnesium, these are the common factors we should highlight on. And as well as that, kidney profile, liver function tests is another considering point. And definitely blood glucose level, because in some cases stress-induced hyperglycemia is there. So definitely we should focus on that as well. Already my eminent speakers already focus on the refeeding syndrome. Yes, it is very contradictory whenever we are giving the feed. So we should focus on the refeeding syndrome should not be happen during the feed, and hyperglycemia, as I already mentioned. So we should focus on that. And on the other hand, the tube displacement is a very common challenge. Whether the tube is blocked or the leakage is there, we should take care of. And definitely the best posture, the best alignment of any patient while we are giving feed is definitely the 30 to 45 degree. This posture is the best option, and definitely we should take on the, if there is high gastroresidual volume or ingestion problem, abdominal distension, then we should modify the feed accordingly. So this is the simple checklist we should focus on before having the trials to feed. And lastly, the precautions. Whenever we are giving the blenderized feed, we should strain the feeds properly and definitely maintaining the temperature. Before prescription, we should know whether the patient is having any allergic reaction to any kind of food ingredients. We should choose the regional and seasonal foods which is available so we can ensure the food and nutrition security as well. Definitely, we should maintain the volume, the consistency, as I mentioned before. And last but not the least, some foods that are not very much consisted of calorie. Likewise, the vegetable soup, the dal water, coconut water, rice kanji, they are not serving many calories. So we should discard this kind of foods which doesn't give you the proper calorie. And lastly, I'm just showing one example. It is consisted of rice 50 grams, whole milk 25 grams, fruits, nuts, oil, and milk. With the combination, it is served 420 kilocalorie and 13.5 grams of protein, and it is easily diluted within 450 ml of water. So these are the common one example I am giving. In this way, we can formulate the Riles tube or the PEG tube feed, and I could say it's an isotonic feed. In this way, we can formulate the feed. So thank you everyone, and whatever I am saying, I am spoken about, it's from this book. Thank you for this amazing book. Thank you so much.
Thank you, Koyal. Uh, there's one issue regarding when it comes to the jejunal pills, that is the diarrhea.
Diarrhea, yes.
So, what you would suggest the practitioners to focus on whenever there is an episode of diarrhea? What checklist they should be doing?
Okay, sir. Sometimes it is happened because of the antibiotic reaction or medicinal issues, diarrhea may be taking place, and sometimes for the supplements for the food ingredients. So before mentioning anything, we need to figure out what is the actual cause of diarrhea. And definitely after that, we should restrict the fiber. We should go for the soluble fiber, definitely. Semi-elemental diet, as already another speaker focus on, and we can suggest for prebiotic and probiotics as well.
Yeah,
And
I
if,
also would like to add it over there regarding the lactose part as well. So, we
yes,
give a
lactose.
lactose-free. Would you like to add anything for that?
Yes.
Lactose?
Lactose-free foods definitely should be incorporated,
Mhm.
sir.
So, milk should not be recommended through the jejunostomy. You
Hmm.
can recommend buttermilk and the preparations of that one. And that is one of the cause. And there's one more cause of diarrhea is like many of the time the patient or the patient's relative or by accidentally the volume of the drips gets increased or it is been increased by someone, and whatever the remaining volume of the feed is there, they would like to exhaust it as early as possible, and that also causes the diarrhea for the patient. So the jejunostomy feeds normally what happens, sometimes the residue gets, gets deposited at the junction of the where the feed is passing from the bottle to the tube, and because of that someone increases the speed, and suddenly there is a influx of around 100 or 50 ml of feed, which also can cause diarrhea. So one has to ensure that we have to educate the patient um, uh, when we are recommending the jejunostomy feeds. So the feed drips have to be very closely being monitored, and very strict instruction has to be given not to increase the speed unless until they discuss with the sister in charge over there.
Thank you,
Yeah.
sir.
Thank you, Koel, for that. I know you're not keeping well, but still you logged in, and yeah, thanks
Thank
once
you,
again
sir.
for that. Yeah.
Thank you.
So we have now Dr. Nancy Sani, and she is going. She is from PGIMR Chandigarh. She is also going to present a plan on the renal conditions, I think. Yeah.
Yeah, thank
Nancy,
you.
over to you, and briefly introduce yourself better than me what I've done.
Yeah, sure.
So
I'm
please
Dr.
go. Yeah.
Chandigarh, PGI, Chief Dietitian and Head of the Department of Dietetics. So I'll be talking on, non-dialyzed renal patients. So let me share my screen. Can you see?
No, not yet.
Okay.
Yeah, desktop is visible.
It's like,
Yeah.
is
Yes,
it
yes.
okay?
Yes, we
Okay,
can.
fine. So I'll be talking on non-dialyzed enteral feeding. So, you know, non-dialyzed chronic kidney disease patients requiring tube feed, the guidelines always focus on customized nutrition plans because you have to preserve the kidney function, manage electrolyte levels. The main challenge is the electrolytes, potassium, phosphorus, sodium, and of course to prevent malnutrition because these patients are already malnourished. And to top it all, there are protein restrictions and all that stuff. So it is a really sensitive area where tube feeding requires a lot of monitoring. So, why it is happening? So the key nutritional guidelines are that first and foremost, protein intake is restricted because we have to reduce the waste product built up and decrease stress on the kidneys. And the focus should be that the protein should be from high biological value if whenever possible. And to compensate for this protein, this thing and the energy from the protein sources which come, so adequate calorie is very important. Remember, if the calorie is not adequate, and if the protein is also lowered down, then definitely it's a formula for malnutrition and higher mortality rates. So adequate calorie intake is essential, and for of the carbohydrates and proteins, carbohydrates and fats, they may be increased, and fluid management is also a very sensitive area in this RT feeding because in early stage of CKD. Patients can usually drink to thirst. However, as the disease progresses, fluid restriction may be necessary to prevent fluid overload, and the total fluid, including water flushes for the tube, must be calculated and managed by a clinician. Daily weighing can help monitor the fluid balance. And coming to the electrolyte management, potassium and phosphorus levels need to be monitored. Restriction is individualized based on the serum level. So it cannot be like one glove fits all. So it has to be, the serum levels have to be seen, and then the tweaking has to be done. So close monitoring is crucial for successful enteral nutrition, and this includes regular assessment of nutritional status, body weight for fluid changes, and serum electrolytes and creatinine levels to adjust the nutrition plan as and when needed. So this is a table which shows energy. It is 25 to 35. It can go up to 40 kilocalories as well to avoid energy deficit. Protein 0.6 to 0.8 grams, and energy should be in place. It is in adherence to the protein restriction strategies aimed at slowing progression, and 25 to 35% of calories from fat to provide non-protein energy. Carbohydrates, remainder of calories after protein and fat, prioritizing low glycemic sources, especially because many of the patients are, they have an underlying diabetic issue. So we have to see what is the source of carbohydrate. And electrolytes, as I already mentioned, potassium, sodium, and phosphorus they have to be monitored according to the serum levels. So if we see the exchange list for this CKD enteral feed, so we have chosen all the foods which are low in potassium and phosphorus. All are basically all the cereals which do not have husk. They are low in phosphorus, and we have chosen this all rice and vermicelli and maize, and there are like 8 exchanges of 30 grams each. Similarly, dals or pulses, you can see green gram, black gram, lentil, roots and tubers, carrot and radish. Now, if you talk about potato, it is very rich in potassium, but then there are ways to incorporate it. If you cut the potato in 4 and if you boil it, and then the potassium is lost. So, but then we are not sure that how much amount we are giving. So all the summer squashes are good for generally good for the kidney patients because they are low in potassium and phosphorus. And if you one exchange of fruit 100 grams, and that also from low potassium fruit list. And nuts is like all the nuts, 2.2 number of exchanges we have added in this type of targeting to around about 2000 kilocalories, and 2 exchanges of milk and fats and oil. So if you see, just concentrate on the total thing. Energy, if it is 1817, then 10% of the energy is coming from protein, 48 grams. 50% of the energy is coming from carbohydrates, so 10 plus 50, 60, and 40% of the energy is coming from fat. So you can tweak it again if the patient is not diabetic, or if the patient has cardiovascular problems. So what you can do is you can shift the 10% energy from carbohydrates and delete it from fat. So that you have to do, that is individualized. Like, you have to see the status of the patient, that what the patient wants. As I already said, one glove cannot fit all. So this was a crux of, this short presentation. Thank you. Questions are welcome.
Thank you, Nancy. Again, it was really a good presentation and a very tough plan to really work out on that one. I would really hate to plan a feed for a renal diet.
Yeah.
I'm quite sure, like, I saw that you're not actually used potatoes and other high starchy foods. There was a question in the chat box, like the rice kanji and other things should not be recommended. To the listeners, I would say nowhere we have used rice kanji, dal water, vegetable soups, or certain kind of a things. Any of the clinical conditions we don't recommend unless until it is recommended for a very clear liquid diet where you just want to give some rest to the bowel. So I'm just addressing the previous questions. Nancy, just let me know if these patients normally have we have to keep on observing the input and output of the volume. So
Yeah.
how you would tweak the plan and how one should use this template for their benefits.
See, the main thing is that, of course, the first is a fluid thing which comes, and definitely the input and the output we have to see, and then I mean, plan the feed, and along with how much water is required for flushing and all, we have to add that up, and then, because input cannot be more than output when the kidney functions are compromised. Then second thing is electrolyte. So what happens is, sometimes nutrition in a practical setup, nutrition feels compromised when we really restrict something. So the doctors do add potassium, phosphorus binders to allow some foods which are high in potassium and phosphorus, because they are rich in protein and they are rich in high biological value protein. So this is also done in some situations. And definitely the fat, we try and add MUFAs and PUFAs in the tube feed. And MCT powders are also available, MCT oils are also available, so we are using that also. So this is what we do about the fat thing. So this is all. And some, now nutraceuticals have come up with the, fiber, this thing, only pure fiber, and which is tube feed friendly. So we have started adding that also, because these patients do suffer from, lack of fiber and constipation and, all these things. So they have helped. Yeah.
Yeah. the template what you have recommended in the book. So that doesn't have any simple sugars as well. So can it be used for the diabetics also?
See, sometimes like we avoid it, but sometimes when when the volume is too low, the energy is compromised with the team of doctors. So they let us, I mean, we as a discussion, they let us add a bit of sugar to increase the energy, and they tweak it with the insulin thing. They say that we'll control it, ma'am, and but you see the energy levels should be optimum. So sometimes it has to be done. If the
Yeah.
sugar
Thank you.
under control, and it is a teamwork sort of a thing. We don't decide it ourselves, so we have to see that the blood glucose levels are not deteriorated.
Got it. Yeah. Thank you, Nancy. So I know you are quite busy today evening. Still, you could take out some time. Thanks once again for that one. However, the
Thanks.
template what has been recommended by Nancy in the book, yeah, it is totally sugar-free kind of a thing. No simple sugars have been added. So it can be used for the diabetics as well. And most of these renal patients are diabetic also. So it adds to a dual level as well. Fine. We have our next presenter, Shilpa Thakur from Delhi, and it is the brainchild of Shilpa Thakur to come out with this document of standardization of enteral nutrition, and she recommended this idea 3 to 4 years back, but we were just waiting for a right occasion to launch this book, and we could find it the right occasion at Delhi itself when we organized this Enteral Parental Sapan conference, and it was an ideal situation to launch it. And I'm quite sure she's quite happy that her project has been materialized and a great contribution to the IPN India. Shilpa, thank you for everything what you have done to make this thing real. And over to you. Please introduce yourself and
Thank
please
you
go
so much. Though it was a brainchild of me, as you shared, but helping and shaping up for thoughts. Thank you so much for this coming up with this book and launching it at SapenCon Delhi. It was really a privilege for me. And I think in context like India, where we've been talking about all these different types of blenderized feeds, there has been many surveys also been taking place, like for the tertiary care ICU. I mean, less than 50% of the patient received commercial formula feeds. So, which indicates like there is substantial use of the blenderized feed still in the hospital or the kitchen feeds. So, I think this kind of work from this complete task force of IPAIN, so it is timely and going to be valuable, especially for the budding dietitians who are going to learn more from it. So, I'm going to present about keto diets and high fat feeds. So basically, if we talk about keto diet and just the concept I'm introducing, so it is for the concept of ketogenic blenderized enteral feeds. And the key idea behind this is that this regime is high fat, very low into carbohydrates, and adequate proteins, which is designed mainly for the therapeutic purpose of ketosis. And this approach is basically important when we are, and when oral ketogenic diets are not feasible, and we need some in certain patients in tube feeding in the ICU, or where we are having some feeding challenges, we need this kind of keto feeds to be used. So typical indications, they include like where the drug resistant epilepsy has been there, or super refractory status epilepticus has been there, or metabolic epilepsy such as glucose transporter type 1 deficiency. So the basic purpose of this enteral nutrition is precision, that we can tightly control fat to carbohydrate ratio into this and ensure the consistent biochemical ketosis also. So if we go to our next slide, we have like two types of ketogenic enteral feeds, the classical and the modified ketogenic diet, which we are covering into this book of ours. And the classical ketogenic diet typically follows 4:1 ratio and 3:1 ratio of fat to the combined proteins and carbohydrates. And this provides actually strong, sustained ketosis, basically, and normally been used for maximum anti-convalescent effect. And the modified one, the MAD, which we call it as the ratio of 2:1 or 1.5:1, it is basically, or MCT enriched formulas, these are basically more flexible ones. And they actually help us with, since they are more flexible, so we can actually tailor made them, the diet based on the tolerance of the patient, on the metabolic needs. We can do the adjustments and what exactly are the clinical goals for that specific patient. So accordingly, we can adjust. It can be suitable for oncology patients also, and in the ICU settings, as I told you initially. So basic principles for the formulation and how to deliver it. So the central principle is the carbohydrate restriction, which we understand from the keto diet like. So this is what which derives into ketosis. And the majority of the calories which are been coming, they are coming from the fat, as we understand. So we with enough protein to meet those metabolic requirements and clinical needs without disrupting the ketosis. This is the basic principle behind this formulation of the keto enteral feed. And when we are formulating this, feeds, we have to consider the energy requirements which are for the patient, the fluid allowance also, which has been required, or whether the patient has been like receiving a continuous feeding or bolus. Accordingly, we need to decide on. So normally in ICU patients, we are using continuous feeding. And those with our delayed gastric empty time, there is also continuous feeding has been used. But because this diet is significantly, this can alter the metabolism also. So we need to monitor many of the things like glucose, ketones, we monitored very, very closely while we are giving this kind of enteral feed to the patient. And during the some kind of a limitations phase, daily checks are very essential to prevent the hypoglycemia, to prevent acidosis or electrolyte shifts, to maintain those all these nutrients. We need to monitor all these things. And while we prepared these two types of ketogenic diets, feeds for blenderized feeding. So we have divided them, as I told you, into the classical and the modified one. So how they differentiate from is like just giving an example of the exchanges which we have used from the different food groups. So for the classical, like it includes the vegetable group, vegetable A group also, the like one exchange of it, one exchange of vegetable B group. Then we have some dry nuts and oil seeds like walnuts, almonds, and pistachios. Then egg white, one exchange has been used. Then soybean has been used. And maximum 8 exchanges of the oil, which can be an MCT source, which can be flaxseed, which can be rice bran. So the total kilocalories which are coming out of it were 2019 with protein of 80.3 and carbohydrate 21 grams and fat 176, sufficing the ratio of 4:1 as we wanted. And on the other side, if you see the modified ketogenic diet, the changes which included were we added pulses and dal into it to increase the protein content. So there was 2 exchanges of pulses and dal group which was been added into it, and the fat exchanges were reduced by 4. So only 4 exchanges of the fat were being used. So the total calories were like 1715 with protein 92, which was been increased as compared to the classical one, and the fat was decreased to 122.2, maintaining the ratio for 2:1, which was a requirement for this. So why we are making these kinds of, keto enteral therapy, this has a strong evidence basically in drug-resistant epilepsy and GLUT1 deficiency. So in ICU settings, especially using this kind of feed, it actually allows us to deliver a ketogenic regime when patients are being sedated or even ventilated also. But we must be aware of the contraindications which are being present into it, that include like fatty acid oxidation defects, which can be primary carnitine deficiency, which can occur acute pancreatitis and severe liver failure. So these needs to be worked with the caution. These contraindications need to be, if they have been present, then we cannot use this keto feeds for the patient. So this diet also can cause hypoglycemia since the carbohydrate content is also on the lower side. So metabolic acidosis or constipation is also. So while we are planning and while we are using it for the patient, it has to be very much individualized and a multidisciplinary approach. I mean, the from the doctor's side, from the help we need to incorporate into it to lower down all the risk possibles which we are being thinking of. So this is a monitoring checklist which need to be monitored if the patient has been kept on to these keto diet. So this monitoring is like very critical, because if we want that our patient needs to be having creating a balance between the feeds and the multiple checklists which we have been doing, then monitoring is very critical, especially in case of the keto blenderized enteral therapy. So we need to have a thorough workup of the baseline data, that what exactly the glucose levels, fasting glucose, electrolytes, LFT, RFT, vitamin D, zinc, and other carnitine, and the patient has been maintaining. And while we initiate in the first week, we need to have a very close monitoring of glucose and ketones into it. GI intolerance needs to be checked onto it. We need to watch for some nausea or, constipation or vomiting or abdominal discomfort if the patient has been feeling. And while weekly monitoring, once a feed has been on, then we have the weekly monitoring of the ketones, specifically in the glucose, and monthly will also include lipids, RFT, LFT, and liver functions and the renal functions. And every 3 to 6 months, if the patient has been carried on still with the keto feeds, then we have to check for the micronutrient contents and the bone markers also, so that the patient has been maintaining all the just to ensure the safety of the patient and improve the overall outcome. This was about the keto diet, and the next which I'm going to present is about for the high fat feeds. So we understand that normally you have seen that high fat formulas are, that means, which consist of more than 40 to 50% of the calories from fat. And these are the specialized formula which are being designed to provide a greater proportion of calories from the fat, as the name has been suggesting. So we have like traditionally standard enteral feeds, which are being like 50 to 60% calories been coming from the carbohydrates, and 20 to 30% from the fat, and 15 to 20% from protein. But in this case, it will be 50% at least calories which will be coming from the fat. So distribution will be different for high fat feeds, 40 to 45 to 40 to 55% from fat, and there is a reduced carbohydrate load into it. So basic principle behind high feed and high fat enteral feeding is that first is the respiratory quotient. The carbohydrate oxidation yields RQ of 1. So while fat oxidation yields 0.7. So we need to actually monitor this thing, that high fat will always reduce the carbon dioxide production in the body. So which is beneficial in case if the patient is having some kind of respiratory compromise. So from this, we can make it out that this is a suitable disease, like clinical indication for COPD or the mechanical ventilation patients. So this kind of a feed is a good source for from the nutritional point. So it helps to maintain the better glycemic control also, because of the lower carbohydrate load, because the major calories are coming from the fat, and it also ensures the essential fatty acid delivery. So in case of the patient has been suffering from patient with advanced COPD or impaired in ventilation or high fat, low carbohydrate feeds, they actually reduce the carbon dioxide and the production and the ease of the ventilator demand. So this is basically better for in case when we are thinking of weaning the patient from the mechanical ventilation also. So in case hypercatabolic states like sepsis, trauma has been there also the high energy needs are being there with fluid restriction. So this kind of feed can work well over there also. So patients requiring fluid restriction or even like special cases, this kind of a feed can also work into if we do not want to go for those classical ketogenic feeds which we have been discussed. So this can also be used in special cases like in some neurological disorders like refractory epilepsy or somewhere we can use this feed also. So there are some contraindications also which need to be taken care while we are using this feed for the high fat feed. So in case if the patient is having severe malabsorption or pancreatic insufficiency, like short bowel syndrome with steatorrhea or something like that, then this feed needs to be given with a caution. We cannot use this thing. And in case of acute pancreatitis, Unless it has been given as an MCT kind of a based feed, then we can use it, but otherwise we need to avoid it. And in case of severe hyperlipidemia also, if triglycerides are more than 400 milligram per deciliter, then we cannot give this kind of a feed. So always we need to, in case of even in inborn errors of metabolism, fat metabolism also, we cannot use this type of feed. And then uh, there are certain precautions like we have been doing. We always have to initiate this slowly while we are trying to feed with the high fat feed. Reason being, we need to avoid the diarrhea, abdominal distension, or delayed gastric emptying. I'll be covering this into my next table also, that what are the troubleshooters and how we need to manage them. So monitoring parameters first is that nutritional adequacy has to be seen while we are planning this kind of a feed, because we are aware of that the major calories are been coming from the fat. But daily calorie and protein intake assessment for the patient needs to be taken care while we are planning this kind of a feed. Then respiratory status of the patient, like monitoring the carbon dioxide, ventilatory weaning, and other tolerance need to be seen while we are giving this kind of a feed to the patient. Then metabolic monitoring like glucose or insulin requirement and triglyceride levels and all these need to be seen. Then the GI symptoms, basically, if there is any kind of abdominal distension which has been present, or there are, like fluid imbalance or gastric residuals are being seen, then we need to actually monitor before we are giving this feed. Then anthropometry measurements need to be taken care. The fluid balance, especially in case of the patient is from the cardiac or renal background, then it needs to be taken care. So if I talk about the foods which are being allowed into this, they are like for blenderized feed, we can use almost all sorts of fresh fruits and all vegetables, whole grains and the rice and the oatmeal, pulses, lentils, dals, they can be used. Unsalted nuts can be a part of this. Vegetable oils like soya bean or peanut or coconut oil and MCT can be used. And the foods which are completely not allowed, like high into saturated fats, trans fats, or the processed cheese. And to maintain the right consistency and the viscosity, we should avoid certain vegetables like potatoes and all, which we were been discussing into the last presentation also, just because we don't want to increase the viscosity of this type of feed. And example for an exchange list food groups for this feed would be like we can have one exchange each of vegetable A and B. We can have 6 exchanges of cow milk. We can have one exchange of fruit. Then 4 to 5 exchanges of the nuts, one exchange of egg white and soya each. And then 8 exchanges of the oils, which can be a combination also of MCT or a rice bran or with the flaxseed oil or the coconut or the soybean oil, which approximately gives around 2.24 kilocalories and 67.8 grams of carbohydrate, and protein is 62.2, with good amount of fat as well as the fiber into it. So this is kind of a just a example to be said what all we can give it in high fat feed, which can be administered safely. But in case we need to be very, very specific with the patient, that what sort of patient we are prescribing this kind of a feed. So this is just a glance on the troubleshooting things or the problems which have been arising and which can be a possible cause, and how we can manage it in case the patient is having diarrhea. Then it can be because of the excessive fat load also. It can be because of the poor absorption also. It can be because of the rapid infusion. That is why I said that we need to be very slow while we are starting this kind of a feed. So slow infusion rate is the first of the foremost priority. Then going on for the MCT based formula rather than other type of fat to be used. And if some kind of pancreatic enzyme supplementation is being required in case of malabsorption, that can be considered. So hypertriglyceridemia has been seen that it can be because of the excess fat intake or impaired clearance also because of some disease condition. So we need to have the reduced fat proportion, monitor the serum triglycerides, and then switching on to a balanced formula if not been succeeded with this high fat feed formula. In case if it is abdominal discomfort, then slow gastric empty time due to fat can be there, and we need to consider the continuous feedings with prokinetics into it, or partial substitution with MCT can help it out. Then hyperglycemia, which is not improving. So it can be because of the excess total calories or the stress hyperglycemia. So we need to reassess our the calories which we have prescribed and to avoid this kind of a symptom. And if there is a tube blockage, then definitely all the feeds we have been talking about, do's and don'ts of the enteral feeds. So if the formula is having very high in viscosity or residue, then it might cause this kind of problem. So flushing or diluting it, which is whatever is necessary, that action needs to be taken. Then fat malabsorption steatoria, that can be because of some pancreatic insufficiency. So maybe like more of MCT based formula might help in this case. So thank you. So basic reason behind this high fat feeds and I mean, like they play a very critical role in specialized clinical settings, as we've been telling, both keto and high fat. And particularly with the patients of like high fat for the COPD or the hypercatabolic states or the stress hyperglycemia or where the fluid restriction has been there. So very careful monitoring of the patient has been required with these types of feed. And when appropriately being used or prescribed, these feeds can definitely help into giving the complete energy delivery which is required by the patient. And it can help into reducing the respiratory burden also and contribute to better clinical outcomes. Thank you.
Thank you, Shilpa. That was really a very comprehensive presentation. If anyone would like to know more about or not have lost a few of your lines in hearing, they can again revisit this recording through our YouTube channels and they can really go through it. I think in this 15-20 minutes, you can really learn a lot about the keto phase. That's how we are actually presented. Thanks for this comprehensive presentation. There are a few questions. Let us have a brief answers for that one. Which feeding route, either the bolus or the probably the drip method they want to say, is better tolerated?
Oh, can
I
you please
think
repeat?
either the bolus or the drip method, which will be better tolerated for the ketosis to happen.
I mean, like bolus is like normally been used, but the other method would work better in a better way.
Either of it
In
will,
case of,
depending upon the patient's condition and how they are faring up.
yeah.
No
So
symptoms.
normally
It,
blenderized feeds are being used if out of ICU settings it has been there, then bolus has been the majorly one which has been used.
right. Which foods can be added for weight gain? And I really don't know what they want to say. And INC and HB. I really don't know what it means to be. So the patient who is allergic to soya and poha undergoing dialysis thrice a week with ESRD. I think egg can be a substitute. Would you
Yes, we
agree
have
for that?
given the options also into that. This is
Yes,
just for
there
the
are.
example. Yes, we've
Yeah,
given the
anyone
options into
who
it.
Neha, you are asking this question. Trust me, when you go through the template, you have many options. I did mention in the beginning, if you are not comfortable with any food item, or if the patient is not tolerant to any food item, or it is not available, you have many options given over there. If someone is not happy with the poha, you have other cereals available to you as well. So, which are those
Yeah, yeah.
cereals? Please refer to the book because we have many presentations. We really cannot answer all the questions. I hope you all understand. We came across a patient who got menstrual issues. How to help in that as she lost good weight? Can you answer this? I really don't know how to.
So it can be a high protein and a high calorie one, which can be, but we are talking about the blenderized feeds.
Yes,
I
I don't
mean,
know why this question is there. How do we manage obese patient with a COPD? I think we have again. I would repeat that you have the template. Please refer to the template.
yes.
And the indications and contraindications are very well mentioned, and the management and the complications troubleshooting is also being mentioned. So I would skip this question, which is already
Even
there
the calorie
answered in
count
the
can
book.
also be managed with the different feeds.
Right. You can alter
Yeah,
the calorific values as well.
yeah.
What is the feed frequency in this keto feed?
So it
Uh,
depends on the patient for whom we are. I
hmm.
mean, it has to be very much individualized.
There's nothing standard kind of a thing. There is nothing like a
Yeah.
fixed kind of a thing. What should be the feed frequency? But in your template, you have mentioned, you have given an option of 8 feeds and 5 feeds. So there
Yes.
are plans of 8 feeds. If you would like to go for a 8 feed frequency, or if you would like to go for a 5 feed frequency. So both the options are available. You can choose any one of them, right?
Yeah, yeah.
Is there any course related to this? No, no, we don't have any course as of now, considering its calorie density bonus tolerated. Yeah. And can MCT be given for a longer period of time?
Yeah, yeah, it can be.
We can give MCT
In
for a
fact,
longer period of time, but
yes,
it doesn't have the essential fatty acids. So we have to be slightly be
it
careful
has
if
to
we
be
are
used in
concerned about
combination, like we
combination.
mentioned.
Yeah,
Yes.
just not the solo. Correct. Yeah. Thank you, Shilpa. And
Thank you so much.
we have our next presenter, that is Dipti Katuja from again Delhi. Dipti, over to you. Please introduce yourself and which plan you are going to present.
Thank you, sir. Thank you, Shilpa ma'am and IAPN for giving me this opportunity. I'm Deepthi Khatuja. I'm heading the Department of Clinical Nutritionist at Fortis Memorial Research Institute, Gurgaon, and more than 20 plus years of experience managing the ICUs and critical care is the expertise. So I'll be talking about the jejunostomy feed since my colleague has spoken about the enteral feeding, the PEG, and the nasogastric, but I'll be touching about the jejunostomy feeding. So, as we know, jejunostomy feeding is something where it is post-pyrolic feeding, and as we all know that enteral feeding is the preferred route, so it is being used majorly where the excess or contraindications are there for the nasogastric or the PEG or the gastrostomy feeding. And it basically, the results have shown that jejunostomy feeding, when done initially at early stages post surgery and indications where the jejunostomy feedings can be done, it has resulted into not just preventing the malnutrition, but decreased hospital stay, decreased infection rates, and to greatly reduce the aspiration risk as well as decrease the chances of pneumonia, and thus resulting into better recovery for the patients, and also to greatly level the aspiration risk by passing the dysfunctional upper GI segments. It is very helpful in. So what are the indications that we have? Just a second, sir. So indications are wherever there is gastric feeding is contraindicated, like we have gastric outlet obstruction, and I think this is something which we commonly seen while we go into the ICUs. The gastroparesis is very common. Pancreatic duodenostomies, where pancreatic and duodenal involvement is there, and these are very commonly used bypassing the upper part of the stomach. So there have been certain indications. These are some of the indications. However, there are contraindications where there is a complete distal small bowel obstruction. It is an absolute contraindication, while there are relative contraindications wherein these factors have to be considered, and we have to assess how effective it is in case of local infections, in case of severe ascites, how effective it is if we go for the jejunostomy feeding. So it is not just a clear-cut no to all these things, but then we have to really get into the deeper thing, how early we can start and what can be the possible benefits if we start early with the jejunostomy, or we can wait and then based on those protocols, we can decide for the jejunostomy feeding. So definitely the studies and researches have clearly shown that wherever, as I suggested, it is a way of doing an early enteral feeding, and significantly reduces the complication of infections and anastomosis, leak, and better maintenance of weight and the albumin levels, and thus preventing the malnourishment. So over here is one of the example of the feeding that we have used and jejunostomy, wherein we have used ragi because that's a good source of iron, calcium, and we have seen that while we go for the jejunostomy feeding, since upper part of the GI
is prevented, the absorption of iron and calcium is greatly impacted, and that's where we try to incorporate this. And we have used a combination of a cereal and pulse along with the soluble fibers and the pumpkin, the vegetables, basically all the food groups we have tried to incorporate. Nuts for the building up the calorie density, oil, and most importantly, what we had a discussion earlier in the lactose free feeds for enteral and jejunostomies. Curd, which is a natural probiotic, can be used as an excellent source where it is tolerated better. So combination of all the food groups giving this 300 ml of feed, giving us 250 calories and 8.2 grams of protein is something which we are able to meet. And the major complication with the jejunostomies is the tolerance, which normally because of which we are not able to reach the adequate calorie and protein, and thus preventing the malnourishment. So here we have tried lot of giving the lot of options in the jejunostomy, wherein different cereals can be used, different kind of vegetables can be used too, so that adequate amount of vitamins and minerals and the right combination of cereal pulse to meet our protein quality is to be taken care, along with the probiotics being added into it. So thank you so much. And any questions, we'll just take it up, sir.
Dipti, in your example, you have considered a ragi, which is a very high viscous. If someone is having some kind of difficulties in using ragi,
Yeah.
so what option you would suggest then?
So we can go for rice, sir. That's very, very easily tolerable. And we can definitely go with that. Or we can go for even jowar also instead of the ragi.
Yeah. So these patients normally have constipation also. That's again, we go back to the same discussion what we had earlier. So would you recommend some kind of added fibers, the resistant fibers, to
So we can
overcome this?
definitely add some soluble fibers to it. And in our settings, we have been using them to prevent constipation as well as to prevent diarrheas in different dosages. And I have seen a lot of impact of positive impact on these patients. And we have tried to, that is the reason we have tried to incorporate as much as the soluble fibers that we can have from the millets and from the vegetables that we, and when we overcook them, definitely the fiber, the crude fiber is destroyed, and that's where we can take the advantage of this.
Yeah, that's good that you did mention about if someone had missed out on the earlier discussion, they can refer to this one. Thank you, Dipti. And that was really, again, a good presentation from your end. Thanks once again.
Thank you, sir.
We have our next presenter, Ms. Pagun Gandhi. Pagun, please introduce yourself and let us know which plan you are going to present.
Good evening. So I would be presenting on two topics, vitamin K and copper restricted diet. Is my screen visible?
Yeah, it's not yet, but
Yeah. Is it visible now?
put it on slideshow. Yeah.
Okay. So vitamin K is vitamin K is a very important nutrient for our body. And what happens is that it is a the main role is for blood clotting. Usually we don't normally look into vitamin K like as a ingredient when we are planning other diet plans. But what happens is there are few conditions that would require a low vitamin K diet. And here, providing them with accurate and low vitamin K diet is very important because they are on some of the other kind of blood thinners. So, blood thinners like warfarin or other blood thinners would require a low K diet given to them. And when there are when the patient is on blood thinners, providing them with accurate amount of vitamin K becomes very important. There are no specific guidelines which suggest that how much of vitamin K should be provided to these patients. But we need to make sure that whatever amount we are giving, we should be giving it more consistently. Because consistency is very important when we are giving feeds like enteral feedings, because it becomes very important when we are giving enteral feedings to decide the amount of vitamin K is to be provided. So if, for example, if a patient is in ICU and on an enteral feed, and if the kitchen staff has made soup using some leafy vegetables into it, which are very high in vitamin K, that can affect the patient's treatment. It can make the anticoagulants less effective, and that can lead to other indications, like there can be increased risk of clotting or stroke, or there can be a treatment failure. So we need to be more consistent about providing low vitamin K diet, and it should stay consistent all throughout the treatment. So usual RDAs for vitamin K are, for men's it is 120 microgram per day, and for women it is 90 microgram per day. And as I told you earlier, there is no specific dose response of vitamin K for warfarin, but we need to adjust the dose according to the patient's INR levels. Also, the thing is that with certain medicines like warfarin, there are guidelines which suggest that the patient should be staying empty stomach 2 hours before and 2 hours prior, 2 hours after the medication. So all of those things also needs to be taken into consideration. So a fixed time of a medicine has to be set. And while planning such diets, you have to make sure that you are making sure that the patient is not taking anything 2 hours before or 2 hours after the medication. So this needs to be discussed with the doctors, and we need to plan the diet accordingly. So, like I told you, the indications are on patients who are on warfarin, or the patients who might have deep vein thrombosis, patients with pulmonary embolism, or patients who are post cardiac surgery requiring anticoagulants. And contraindications can be when the patients are having certain amount of coagulation disorders, or they are at a high risk of bleeding, patients who are have malabsorption disorders, or there are liver diseases. So that needs to be taken into consideration. Also, there are a few things that needs to be avoided which are very high in vitamin K. First is all forms of leafy vegetables. So all leafy vegetables and cruciferous vegetables needs to be avoided strictly. Those things have to be avoided. After that, you have to make sure that no soya bean or canola oil has to be given, and certain fruits like kiwi, avocado also needs to be avoided. Also, our patients are used to taking some herbal powders and all. So when they are on vitamin K restricted diet, we need to make sure that they are not taking different forms of herbal powders. Or many of patients start multivitamins themselves. So we have to also make sure that they are not taking any multivitamins which would have vitamin K in it. Also, to make a note that many of our oils are fortified with vitamin K. So we need to make sure that the oil is, so we have to make sure that the oil that we are using is not fortified with vitamin K. And for practical tips while planning this is, we need to make sure that a, we need to maintain the steady formula, opt for local and seasonal products. We can adjust the calories like by adding oil, or we can just adjust the calories using that. And also we need to make sure that we are tracking the patient's INR levels more frequently. So all of those things are need to be like we need to take into consideration. And also while counseling the patient's relative, and the kitchen staff, when the patient is admitted in the hospital, needs to be counseled very well about the detailed list of things to be added or things to be avoided. Any certain or sudden changes, even simple and vegetable choices, can lead to increased amount of vitamin K intake, and that can decrease the effect of anticoagulants that the patient is having. Thank you. And so should I
Thank you,
continue
Gogol.
on my second topic, or
Yes, yes, please. Yeah.
yeah? So and my second topic is copper restricted enteral feeding. Copper restricted enteral feeding, or in general, if we say a copper restricted diet, is very rare. We normally hardly see patients who would be on copper restricted diet. But there are few patients, or there are few conditions that would require copper restricted diet. And first being Wilson's disease. Wilson's disease is a condition where it is a genetic defect where there is the copper excretion doesn't happen properly, which results into copper accumulation in liver, brain, and kidneys. and this can cause progressive damage. So here we need to make sure that dietary copper control becomes very important. We need to make sure that the patient is taking low copper diet at this time. Like same for vitamin K, here also we don't have any specific restriction for copper intake. But when the patient is during the initial phase of treatment, we need to make sure that we are keeping a stringent copper restricted diet, and we need to see that what kind of other gelation therapy or zinc therapy that the patient is on, and based on that we can adjust the copper intake for the patient, but it should be always lower than the RDA. So RDA for copper is 2 milligrams per day. So we need to make sure that we are giving copper which is around 1 milligram or less than that, depending on the discussion with the doctors. By the stage or the phase of the treatment the patient is on. So indications is Wilson's disease. There are no, as such, there are no contraindications for this. So we need to make sure that just the patient is not malnourished. So if the patient is malnourished, there are chances that when the patient is on copper restricted diet, the patient's iron calcium levels also might go low. So the multivitamins or we need to replenish it properly, and also that we don't have to eliminate copper completely. It is an essential mineral, so we need to reduce it or restrict it. So what are low copper foods? So low copper foods are rice, oats, wheat, barley, corn. All pulses can be added in small quantities except soya. Soya is high copper food. Milk and milk products can be used freely. They don't contain much of copper. And vegetables can be used. Only few things we need to avoid are all forms of non-vegetarian sources. Apart from that, all forms of seeds and nuts, they are very high in copper. So if you are taking very small quantity of it also, like we feel that it's not going to matter much, but they do have a significant effect. And all what like water becomes a very important source of copper, so we need to make sure that we counsel the patient not to drink water from a copper bottle, or not to use RO or filters at home which would have copper installed in it, or simple as using some cookware which would have copper. So all of these things also would have like there can be also be a source of copper contamination. And also there are few additives that are added to food for preserving it, which would have copper in it. So we need to make sure that such forms of copper is also not going on for the patients. And few practical tips is we always counsel the patients that we need to use filtered water and avoid copper cookwares, or like if there are pipes which are running which would have copper, which are very rare nowadays. But still, if there are in certain places, we need to make sure that the patients are not using that. Using of stainless steel or glass for cooking, and also to check the food labels for copper compounds, and also to monitor the liver functions and symptoms regularly. So if the condition is improving, we won't need to restrict copper very stringently. If their condition is improving, we'll gradually increase the copper levels also in their diet, so they get all the adequate minerals that are required for them. Thank you.
Yeah, Pagun, that was really a good presentation. Copper and vitamin K, very rarely we come across these plannings. And anyone who may be seeing regular patients, this would be a very handy kind of a thing.
Mhm.
And you rightly did mention about one thing. What we actually forget about is the water purifier, which may have copper content in that one. And we normally don't advise patients when these things should be kept in our mind. Uh, any specific oil for vitamin K, because oils are being seen as like they are rich in all ADK vitamins. So, but is there any oil which is deficient in vitamin K? Any idea on that?
So, sir, canola oil is deficient in vitamin K. So, canola oil can be used while cooking or while adding to the soups or the blenderized feeds.
Yeah. Even they say, I'm not sure, but even the fish oil is also being said that it is less in vitamin K. Probably we can know
Okay,
more
sir,
about
even
it
I'm
once
not
we
sure
know
about
more.
it.
Yeah. I know. I just had just worked out just today evening only. I was also not knowing for that one.
Yes,
So
sir.
thank you, Pagun. Yeah, as we are running late, so we have our next presenter. Sunita Sahu.
Thank you, sir.
Sunita, welcome, and please introduce yourself and go ahead with your presentation.
Hello, good evening, everyone, and thank you for giving me this opportunity. I have a very short presentation, and my topic is fat restricted enteral feed. Uh, is it visible to everyone?
Yes.
Okay. This is a very specific means like type of feed which we use. Just a minute. Yeah. Why and when we need fat restricted feed. Fat restricted enteral feeds are specialized nutritional formulations designed to limit long chain triglyceride while ensuring adequate energy and protein delivery, often with supplementation of medium chain triglyceride. We all know, means like we have to keep carbohydrate fat protein ratio in our enteral feed, which is like carbohydrate should be 50 to 60%, fat should be like 25 to 30%, and protein is also means like 25%. But in these feeds we have to restrict the feed, means like fat content of the feed, and the major component of the fat is usually we use MCT oils. The primary advantage of fat restricted feeds lies in reducing lymphatic flow, steatorrhea, minimizing gastrointestinal distress, and improving tolerance while allowing energy provision through rapidly absorbed MCT. These are the indication when we can use these fat restricted feeds like chylothorax, chronic pancreatitis, short bowel syndrome, fat malabsorption, and certain post surgical states involving the gastrointestinal and lymphatic system. Foods to include, like I have given a chart where in fat restricted diet we can include all type of cereals, because we have to take care of the calorie count and protein also. Millets, pulses, vegetables, and fruits, and vegetable except avocado, because we all know avocado is fat. So boiled, means like boiled egg white, like lean chicken, skimmed milk, milk powder, we can use. Medium chain triglyceride oil, coconut oil, as fat sources we can add, and supplements with less than 3 gram of fat is recommended. Foods to be excluded: groundnut, soybean, flaxseed oil, etc., ghee, banaspati, butter. All this cannot be added in this type of feed. All types of nuts, oil seeds, almonds, walnuts, groundnuts, and fatty fish, mutton, egg yolk cannot be used. Bakery product, bread and biscuits. Uh, Along with fat restricted enteral feed, means like a few patients also given iodine. This is another feed which I have included in my presentation. When to give this iodine restricted enteral feed, certain thyroid cancer patient who undergo surgery may develop chyle leaks, where fat restriction become essential to reduce chyle flow, and when combined with iodine restriction, it supports both surgical recovery and preparation for radioactive iodine scanning therapy. So this is a special case, means like where cancer centers are there, or the dietitian who are taking care of special cancer patients. For them it is a very important feed. They can consider this, and indications are thyroid cancers, preparation for radioiodine scanning or treatment. What are the food allowed in this iodine restricted diet and fat restricted? Especially these are allowed, like crystal salt, kosher salt, Himalayan salt. These are usually low in iodine, that we can consider in the feed. All vegetable and fruits, egg white, lean meat, vegetables oil, especially MCT, and whole grain cereal, pulses, dal, unsalted nuts can be used. But the normal salt, iodized salt, milk and milk product, lactose, whey, casein, dairy, chocolates, soya products, egg yolk, all these cannot be used in low iodine or fat restricted diet. Instruction: iodine may be present in various dietary supplements. Read the label on packaged food for iodine content. Whatever the means like ingredients you are using for the feed, you have to check the iodine content of that particular ingredients. Preferably, iodine should be less than 5 microgram per feed and less than 50 microgram per day. Iodine, if present in the form of potassium iodide, sodium iodide, still needs to be avoided. Check multivitamin mineral supplements for their iodine content before using for such type of patients. This is the food exchange list for fat restricted feed I have given. You can see all cereals, pulses, vegetables we can use, fruits we can use, but fat in the form of MCT. These are the sources we can use for MCT, and we can prepare our feed. Drawbacks of low fat feed, like potential for essential fatty acid deficiency. Those who are on this low fat feed may be like fat soluble vitamin deficiency may happen. Impaired absorption of fat soluble vitamin, risk of inadequate calorie density if not carefully balanced. So in this type of feed, while preparing the feed, we have to take care of the calorie restriction, which should be come from carbohydrate, not fat. So that is very important while formulating the feed. This is some like 3 feed sample feeds I have given, which consists means 250 ml and one is 400 volume feed, from which 250 calories, 7.6 gram of protein we can get, and from 400 ml volume, 417 and 13 gram of protein you can give. So this is a combination of low fat enteral feed, which you can consider for this type of patients. And many such feed recipes in different permutation and combinations you will find in the book. So get your copy today. Thank you.
Thank you, Sunita. Again, a few rare cases what we have presented over here. So, and as you see, there are no questions being put up. In case if you see any questions put up later, please answer on the text box.
Sure, sure.
Thank you once again. And we move to the next presenter. There's the last one, Rajeshwari. Please introduce yourself and the plan what you're going to be presenting. Over to you.
Thank you so much, sir. Thank you so much for the opportunity. Hi, I'm Rajeshwari. I'm working as the dietitian in Homi Baba Cancer Hospital, Vizag. So my presentation today is on pediatric enteral feeds. Is my screen visible?
Yeah.
Okay. So the reason why pediatric enteral feed is of utmost importance is mainly because that if you take any pediatric population, their meeting their nutritional requirement becomes important mainly because to support their growth and development. Yeah. So any children that walk into your hospital or any kind of setup, it is necessary to understand that they will have a higher nutritional requirement in comparison to any other population, mainly to meet their increasing demands for meeting their growth and development as they age. So in children, EN is primarily indicated in many conditions wherein they have a functional gut, but these nutritional needs are not met only through their oral intake. And mainly in cases like when the patients are having any kind of gastrointestinal diseases like short bowel syndrome or irritable bowel disease, or any inflammatory bowel disease and celiac diseases, or in case of any neurological disorder like cerebral palsy, or in case they have any swallowing issues, which can impose a high risk of aspiration in the kids, and then any kind of congenital and structural disorders wherein oral intake is contraindication, but then their enteral route is still functional. In all such cases, enteral feeding route passage of an NG or an NJ tube is generally recommended for the kids. And in case their requirement is very high, even if their oral intake is optimal, but then their metabolic demands are high in conditions like cystic fibrosis or HIV, AIDS, and cancer patients, wherein their per day requirement will not be just met orally, then an enteral route is indicated. Other cases wherein it might be of importance is when they are severely malnourished and their oral intake does not meet their requirement. Again, an enteral nutrition is indicated. And in critical illnesses wherein the kid is in a PICU or if the kid is ventilated, even such cases, an enteral route can be recommended for the child. The only conditions wherein the enteral feeding is contraindicated will mainly include conditions wherein their enteral route is not functional, either because of obstruction or because of any kind of GI bleed, or if the kid has any uncontrolled vomiting, diarrhea, if the kid is not hemodynamically stable, or if they have any kind of high output fistula. But again, in high output fistula, if feeding is possible in a distal area after the fistula area, then even then we can go for an enteral feeding. But if in case the fistula is at a site wherein it is contraindicated to feed the child, then it is again coming as a contraindication. And in case of paralytic ileus also, we do not go in for any kind of enteral feeding. Generally, in case of kids, we will have to keep in mind that their protein requirement in comparison to the calorie requirement is the ratio is very low, wherein their caloric requirement is higher than the protein requirement. The reason I'm not showing any guidelines and cutoff is because pediatric again is a very vast area. There are different conditions and different requirements for various kids, and there is not one particular thing wherein I can take out and say that this is the particular guideline that you're supposed to follow. So in the book also we would have gone with the RDA just to give an idea as to how we can plan pediatric formulas for kitchen feeds for such kids. So the main foods that are allowed in such conditions, any kind of fruits, vegetables, which include green leafy vegetables or root vegetables, grains, rice, whole grains like rice, oatmeal, pulses, dals, any kind of nuts like walnuts, almonds, cashews, and even sugars can be allowed in case it is a pediatric population. And one thing that we need to keep in mind while you are going to plan the feed is that in pediatric population, the tube that is being inserted will have a very low French size in comparison to the adults. So the probability of the tube getting clogged is very high. So if you see in adults, probably the 16 or the 14, depending on where the tube is being placed, the French size will vary. But in case of pediatric, it can be even as low as 8 and 10 as well. So in case which is the French size being that low, any even little viscosity can end up clogging the tube. So we should make sure that right consistency and viscosity has to be maintained. So in order to maintain this, certain food items that can increase the probability of clogging the tube like bread, biscuit, chapati, or vegetables like lady's finger, brinjal, potato that can cause a gelatinous substance at the end of cooking. Sago, raw eggs, and meat are generally avoided. Raw eggs and meat, again, it is avoided because of the high clogging probability and also because of the high contamination risk. So this is just an example of the exchange list which is being used across the age group of 1 to 3 and also 7 to 9. I have just given an example as to understand how different combinations has to be used in order to meet the calorie and protein requirement. So if you see here, I would have used not just one ingredient. What many people do when feeding in through enteral route is they either give only rice or they only give vegetable soup, but then you will have to use it in combination to make sure that the calorie and nutrient and the protein needs are met. At the same time, making sure that the other micronutrient requirements are met. So if you see in a 1 to 3 year age group, the caloric requirement that I've shown here is as per the RDA, and similarly for a 7 to 9 age group also I've just given a reference value so that you will have an idea as to how to go about it. So here to increase the calorie and protein requirement, the exchanges are being modified. If you see here, the cereal requirement, pulses requirement, the ratio and the ratio in the 7 to 9 will vary depending on what the requirement has to be met. So instead of the pulse that I've used here, you can also go in for other alternatives like soy powder and things. to replace in case the kid does not tolerate soy, then you can go in for the pulse variety as well. And in case it is a cereal, the reason I've used ragi here is because it's locally something that is being practiced in our area. So that is the reason why we have still given that. But again, when you're preparing ragi, it is something that forms extreme gel-like substance. So once you prepare it, you should educate the parent that it has to be cooled down, after which it has to be diluted using either milk or water, depending on how much calorie and protein that you have to meet. And then depending on your area availability, local grown vegetables and fruits have to be prepared. And again, keeping in mind the volume of the feed can be determined based on what the viscosity that you need to give through the tube. And additional clinical considerations that you have to keep in mind is there are certain setups in India wherein the dietitian might be the one who are doing the tube placement. So every time you do a tube placement, ensuring the position before starting the feed, monitoring biochemical parameters, especially in kids who are under severe malnutrition, they might go into refeeding. So you will have to make sure that their serum electrolytes like phosphorus, magnesium are monitored regularly. And there are chances that they might go into fluid overload. So then again, their sodium, potassium values have to be monitored. And to know if the kid is tolerating the feeds or not, it is necessary to check their GI tolerances, like their stool consistency, monitoring the stool pattern, whether they're having any kind of abdominal distension post feeding, if they're having nausea or vomiting while feeding. And all these things can be ensured by taking a recall, or even simple things like checking their position while feeding can make a difference in them. Second thing is that there are certain kids who will have personal intolerances apart from the disease per se, like they might have lactose intolerances or gluten intolerances. So in such cases, you might also have to go in for a lactose free option in case of pediatric population. And every time you are going to start feeds for pediatric population, you need to keep in mind that unlike adults, they have a very low stomach volume. So in that cases, every time it is advisable to start the volume very slow, and gradually we will have to increase it based on their tolerance. It can take over a period of week also to step up the feed, but then you will have to step up the feed only after checking their GI tolerance and by also tracking their biochemical parameters. And we will have to avoid any kind of empty calorie items like juices, coconut water, rice kanji, and dal water in kids, because again, that is not going to add into our nutritional benefits or to meet up their nutritional recommendations. So anything that lacks nutritional density and do not grow their support their growth has to be avoided. And always make sure that you're going to use nutrient rich recipes while you're planning the feeds. And as I mentioned earlier, to avoid any kind of raw egg or meat through the tube, especially because in India the eggs that we get are not pasteurized, so the risk of getting infections are very high, and also the the chances of it clogging the tube is very high. So main thing is, as I told you, the French size is very small, so you will have to make sure that you avoid foods that can clog the tube because of their extra stickiness and the property of such foods. Thank you.
Yeah, that was really a very great presentation, Rajeshwari. It was very complicated. I know
Thank you
how
so much.
difficult it was to plan you for all those when you want to, whenever you want to increase the calories, the protein that were actually a kind of a issue for you. Along with that, the proteins were also increasing, and that was crossing the RDA requirement. So it was so, how much time you took and how much of permutation combinations you worked out to achieve those required calories and proteins. In pediatric, meeting those calorie protein in those ranges is very challenging. So
Yes.
thanks for that. And the plan what you have shared in the book is also really very easy to be followed. There's one question, two questions are there. Very simple one. Why we should avoid sago?
Uh, Actually, as I told you, anyone who has used sago in cooking will know that it swells up after quick cooking, and once it cools down, it starts forming gel-like substances. So once it's passed, if you try passing it through the tube, it can clog the tube. So that's the reason why we generally
Yeah,
avoid sago. And again, it is going to contribute to empty calories again.
right. And what's the protocol in case of neutropenia?
generally, whatever we are going to use through the feed are going to be cooked and consumed immediately. Anything raw has to be avoided when you're going to follow a neutropenic diet. And when the any vessels that they're using or cooking procedure, the person cooking, everyone should follow proper hygienic practices. Unpasteurized things has to be avoided. So if any plant that you see in our diet will always involve cooking the vegetables or cooking the rice and boiling the milk over high temperature. All these things can ensure that the risk of developing neutropenia through infection is restricted in such cases.
Yeah, that's right. Thank you once again, Rajeshwari. And we are at the end of our today's presentations. At the outset, I would like to thank the other authors who couldn't join today due to various reasons. Bhakti Samant, Bhavna Gandhi, Swati Hegde, Vanessa Almeida, and Sadaf Fatima. Thank you for all your contributions to the book and to the plans. And over to you, Prasanna.
Yes, sir. So, thank you. First of all, thank you for all participants who have shown patience during this 2 hour fruitful discussion. And my thanks to IAPN India Association for organizing this meaningful program and also allowing Venkat Nutrition to be associated with it with value of this collaboration and opportunity to contribute to the advancement of clinical nutrition practices. I would like to thank all the participants and special thanks to all 12 experts and Dr. Shushankar for guiding this session smoothly and moderating the session throughout this program for 2 hours. And once again, thank you for being part of this webinar. And we look forward to staying connected and working together in future initiative. Thank you and good evening, all of you. Yeah,
Thank
thank
you
you.
all. Good night. Yeah.
Yeah, thank you.
Thank you so much.
Thank you, everyone.
Thank you, everyone.